Hi, everyone. My name is Georgia Vasilakis Tsatiris. I'm a chief medical resident at the University of Pittsburgh Medical Center and a fellow of the CardioNerds Academy.
Hi, everyone. My name is Anna Radhakrishnan. I'm a third-year internal medicine resident and incoming cardiology fellow at the Mount Sinai Hospital, and like Georgia, a CardioNerds Academy fellow. We are so excited to be back with Dr. Kevin Alexander today to discuss the latest results coming out of ESC 2025. Dr. Alexander is an assistant professor of cardiovascular medicine at Stanford University School of Medicine. While he sees a wide variety of advanced heart failure and transplant cases clinically, Dr. Alexander has a particular expertise in diagnosing and treating cardiac amyloidosis, a common rare disease that is an underdiagnosed cause of heart failure. Dr. Alexander is at the forefront of enhancing our understanding of this condition with grant support from the NIH and AHA, among other sources. Dr. Alexander, we are all so excited to learn from you once again and great to see you again.
Thanks, Anna. Thanks, Georgia. Great to be here.
So today we'll be discussing cardiac amyloidosis updates from ESC 2025, specifically new analysis from the ATTR-CM trial. So to get us all up to speed, Dr. Alexander, could you briefly summarize the design and top-line results of the phase 3 ATTR-CM trial?
Certainly, yes. So ATTR-CM was a phase 3 randomized controlled trial studying patients with either wild type or hereditary ATTR and seeing the role of Acoramidis for treating these patients. Acoramidis is a highly selective, near complete TTR stabilizer, and in the phase 3 ATTRibute-CM study, had strong clinical trial results for hard cardiovascular outcomes, cardiovascular hospitalizations, and mortality, as well as other secondary endpoints. And so that's led to the approval of Acoramidis to treat ATTR cardiac amyloidosis patients in the US, Europe, and Japan.
That's great. Thanks for the recap. So your latest study that you presented at ESC 25 presents post-hoc analyses focused particularly on atrial arrhythmias, so atrial fibrillation and flutter. What was the rationale for this focus, and how do these analyses differ from the prior ones in the ATTRibute-CM program?
Yeah, so I think by way of background, it's important to note that about 2/3 of ATTR-CM patients have concomitant atrial fibrillation, and that can confer additional morbidity and mortality as it does for other cardiac conditions. There's been a lot of analysis out of ATTRibute-CM and other phase 3 amyloid clinical trials that have looked at outcomes such as cardiovascular mortality and survival, but not as much data about the impact of therapy on atrial arrhythmia burden. And so the goal of this analysis was really to look at post hoc subgroup data, specifically addressing the burden of atrial arrhythmias in this trial population.